Morning, everyone. Today the class is on ECPR. So we'll start with advanced life support is the standard of care. But what if advanced life support doesn't achieve ROSC? Then what we are left? We are left with ECPR. So we are gathered here to discuss on that. So what is advanced life support? High quality CPR, defibrillation, vascular access, drug therapy, adrenaline and amiodarone, airway management, intubation. We continue this for another 30 minutes till your ROSC is not achieved. Then we move toward ECPR. So, and in refractory cardiac arrest, so what is the option? So only option is you can try ECPR, but not suitable for all patients. What is ECPR? Emergency initiation of ECLS during refractory cardiac arrest, cannulation and high quality CPR undertaken simultaneously. Variety of settings it can be done. Emergency department, ITU, cath lab or pre-hospital. Augment and organ perfusion and hemodynamic during arrest. Buy time to identify, treat underlying cause and achieve ROSC. Example can be pulmonary embolism, myocardial infarction, drug overdose. So ECPR, what kind of ECMO we generally use? So when we are talking about ECPR, it's 99% VA ECMO. That also predominantly percutaneous ECMO. In some settings, we can do central ECMO. So keep calm and save a life. So which patient will be suitable for your ECPR? There should be a proper selection. All patients are not suitable for ECPR. So first, age should be less than 60 years. Initial rhythm could be ventricular fibrillation, VT, chest compression within 5 minutes of arrest, refractory arrest more than 30 minutes, no ROSC despite standard ALS, no major comorbidities, likely reversible cause. So this is the trend, how ECPR has adapted. You see from 1992 to 2017, this is the data I took from the ELSO registry, how the number has significantly increased in last decades. So what are the golden hours of ECPR? So first 30 minutes is the golden hour for the ECPR for a better outcome. First 6 to 20 minutes, percentage of survival is quite better, more than 60%. As your time passes, your survival start decreasing. After 45 to 60%, 45 minutes to 60 minutes, your survival drastically decrease less than 10%. This is the trend in survival after in-hospital cardiac arrest. So this was the survival you can see in VF and VT patient where ECPR was tried. Survival to discharge was almost near to 30%, whereas in asystole patient, survival is between 5 to 10%, and overall survival is between 10 to 15%. This is the ELSO registry data, which shows how many percent of VA ECMO survived due to ECPR is 29%. This is ECPR survival rate by age group. So pediatric and neonates do much better in ECPR compared to adult. Their percentage of survival in pediatric is 42 and neonate is 40%, whereas in adult is 30%. This is in hospital versus out hospital survival to discharge by ELSO registry. In hospital it is 34.2, out of hospital it is 27.6%. This is one big study was done in Japan by SAVE J2 study, where it was studies and result showed same thing, that in hospital survival is more, and it is up to 46%. This was studied around 2000 patient was studied, and this is the largest meta-analysis done for ECP. ECPR selection to target ischemic cardiac arrest, witness cardiac arrest, no known comorbidities, immediate initiation of CPR, no flow less than 5 minutes, uninterrupted, good quality of CPR, ETCO2 more than 10 mmHg, shockable rhythm, no sustained ROSC, sustained ROSC able to maintain a perfusion rhythm for at least 20 minutes, able to achieve support within 60 minutes of arrest. This is how devices help in ECPR. This is an automatic CPR machine which provides good quality of CPR. And it does not waste time during change of the hands. So now question comes, when your patient is selected for ECPR, what cannulation configuration you will be using? Mostly it will be VA ECMO and usually it will be percutaneous femoral access. What are the cannulations we do in ECMO? So femoral, axillary, common carotid, central cannulation. If we are doing ECPR for uh, uh, patient, it's generally percutaneous femoral, but if it is post cardiotomy, it's better to do central cannulation. If your femoral vessels are not accessible, then you can try axillary also. This is showing the photos. These are femoral cannulations. These are the axillary. And this is the central. This via ECMO cannulation. This is VVA. And this is how percutaneous cannulation done on the both the limb simultaneously with the distal limb perfusion. So what imaging modalities you will use during ECMO cannulation? Gold standard is fluoroscopy guided. If you don't have option of fluoroscopy, you can use ultrasound or TE, transesophageal echocardiography. So this is how it looks during fluoroscopy guided cannulation. You can see your vessels very well with the femoral head, so you can have a better judgment and a safer cannulation. This is the hybrid cut down technique for ECPR, where percutaneously could not be achieved. You can cut down and expose the femoral vessels and you can do cannulation. In this, they have used horizontal incision compared to vertical incision. Even you can do vertical incision. It depends on the surgeons who is cannulating. Steps of cannulation. Clean the groin site with topical antiseptic, ultrasound location of vessel, micropuncture or 18 gauge needle access to femoral artery and vein, insert guide wire, long guide wire, and create skin nicks, dilate vessel with serial dilator, commonly 15 to 17 French for arterial cannula and 21 to 25 French for venous cannula. Insert ECMO cannula, connect the ECMO cannula to circuit using wet to wet technique to exclude air, unclamp cannula circuit to initiate flow. Ultrasound for ECPR vessel cannulation, assuring proper vessel selection during low flow state of ECPR because there will be no pulse, so you can't get proper judgment. Vessel sizing for cannula selection, evaluation for anatomic variation anomalies of the vessel, determination of vessel access level, assuring midline vessel entry, assessing presence of distal arterial perfusion, integrate distal perfusion cannulation if needed. This is how it looks in your USG guided cannulation. This is for arterial cannulation. This is for venous cannulation. So this is theoretically whatever the diameter of your vessel, you can multiply by the 3 which is says the maximum size of the cannula you can use. For example, the vessel size is 6, then you multiply by 3, then you can maximum achieve 18 French of the cannula. You can cannulate till 18 French, you can't go more than that. But this doesn't always be used in ECPR because patient will be on cardiogenic shock, multiple inotropes will be there, so vessel will be constricted, so it will under-determine. This is semi-percutaneous cannulation. So there are 3 stages of cannulation. First stage is vascular access. Place patient on mechanical compression device, place board under patient pelvis, place femoral venous and arterial sheath. So when patient arrest, at the 10-minute, even if you're not planning for ECPR, if your patient is ideal candidate, just put the arterial and venous sheath and wait for your clearance for ECPR. So you don't waste time in the later stage. Stage 2, cannula placement. Request ECLS specialist to prime the circuit. Get the cannulas. Get the venous cannulation and arterial cannulation. Give heparin. And stage 3, connect the circuit and initiate the flow. So this is the how first stage looks, where your seats are already achieved. If now you are after 15 minutes, you get a go ahead for the ECPR, you can directly go ahead with the cannulation. Your seats are already there, so you have to just pass the guide wire and put the cannula in. This is can be used in ECPR because all the patient will be having constricted vessels. So this is the cannula which is self-expanding, which can
this is the metal snare. Once we push it, it will get shinged. As you can see, this is shinged. You can pull it out one with. This metal snare will go again back to normal shape of the venous artery. This is
after achieving the cannulation, what can it go? In case where the pump was persistently low or decreased flow, despite increasing pump speed, clinicians should consider the following etiology as the cause of low flow. You have connected your cannulas, you have went on the circuit, still you can't achieve your flows, then you have to rule out for all these things. Extravascular cannula, venous drainage insufficiency, hypovolemia, bleeding, tension physiology in the chest or abdomen, pericardial tamponade, tube kinking, insufficiently large drain cannula, arterial return obstruction, high vasopressor doses, tube kinking, insufficiently large return cannula, large membrane lung clot on your oxygenator. Role of ECPR team. Call in-house ECLS team to the emergency department for ECPR. Perform stage 1 cannulation, ultrasound guided percutaneous, 7 to 9 French cannulas for sheath. Preparation for stage 2, guide wire exchange for ECLS cannulas. Place early in course of CPR to save time. Perform ECLS cannulation. Collaboration with other service. It is not single person game. Surgical team. If there is a failed percutaneous cannulation, vascular complication, intensivist, transition of care to the ICU, perfusionist assistance with technical issue and institutional support. This graph shows that you should take time as a consideration. If you are crossing the time, you should stop on your resuscitation. Even if you had go ahead with the, if you can't achieve your flows within 16 minutes, you have to stop. You should not persist with the cannulation because after 60 minutes, it's a irreversible damage to your neurons and body. So even if you achieve the flow, you technically save the heart or you achieve the flow, but there is no brain. Key management priorities: the first hour after cannulation and achieving the flow. Please, we have to follow all the checklist. Establish patient and circuit monitoring. Optimize hemodynamic, right upper extremity arterial line, ECMO blood flow, vasopressor, blood and fluids. Optimize gas exchange. Tighter your sweep to arterial blood gas. Ventilator settings. Complete initial diagnostic, your ECG, echo, CT, ultrasound, CAG. Identify and manage underlying pathology, cardiac cause, non-cardiac causes, exclude CPR complication, prevent and recognize early ECMO complication like LV distension, bleeding, anticoagulation, distal limb perfusion, differential hypoxia, determine patient disposition, recognize the unsupportable patient, debrief with ECMO team. This is how you assess according to system wise and targets. For neuroprotective, you look for targeted temperature, CT brain to exclude your neurological injury. For severe system, you'll look for your map, flows, ECG, echo, inotropes, your distal perfusion cannula, internal jugular site, and minimize complication risk. Pulmonary, you'll target your ventilator, low tidal volume, your PEEP. Hematology, you'll look for your RBC, platelet count, fibrinogen, INR. For renal, you will see your electrolytes, whether your patient needs CRRT, dialysis, how is the urine output in first few hours after you're achieving the flows and other systems. ECMO circuit check, ECMO pump, power electricity on, revolution per minute. You will look for your RPM, you look for your desired flow, look for the pressure, look for your sweep gases. Your heater is on. To maintain your patient temperature is very important, and look for your tubing and membrane learn, and look for your color change in your cannula. Circuit catastrophes: air in the circuit, accidental decannulation, circuit rupture, pump failure, circuit clot. What all complication can occur during your ECPR? Most common is your vascular injury to your femoral site, GI bleed, retroperitoneal bleed because of your cannula at malposition, cardiac tamponade, intracerebral hemorrhage, pulmonary hemorrhage, cannulation failure, sepsis, leg ischemia due to distal limb perfusion. So on Sunday there was two ECPR was done in our setup. So I'm just presenting both the cases. The case one, this was 53-year-old male. He was diagnosed outside non-STEMI. CAG showed osteal LMCA plus triple vessel disease. Patient received with severe cardiogenic shock with severe LV dysfunction in acute pulmonary edema. Patient initially presented to Kaveri Hospital with cardiogenic shock and STEMI. He was intubated and started on vasopressor and inotropic support. Coronary angiogram was done and with IBP support, which revealed osteal LM plus TVD. Patient was advised there for CABG. Later, patient came to NH. Before transfer, IBP was weaned from Kaveri and patient was shifted to NHER. After receiving the patient arrested in the ER. It was witness arrest. Immediately, CPR was started. As per ACLS protocol, ROSC achieved after 4 cycle of CPR. Patient developed recurrent cardiac arrest, given refractory arrest. So ECPR was initiated and ROSS was achieved with a total downtime of 34 minutes. So clinical status on arrival, patient was intubated. pressures were very borderline, 7 to 50. Neurological bilateral pupils was 2 mm, non-reactive. ABG was showing severe metabolic acidosis, lactate of more than 15. So this was the after achieving the circulation. Patient after 34 minutes achieved a 3.6 liter of flow, and after 12 hours, patient.
1 second, Deep. How can you get a map of 96 when the BP systolic BP is 70? Does it look correct?
No, sir. Map I am not told
You've
only.
written there 96.
So
SpO2 86, map 96, BP is 70 by 50.
so this was, I think, this was before initiation of ECMO. After ECMO, the map was 96.
No, no. How can you put a BP of 70 by 50 with a map of 96? It just doesn't make sense.
Yes, sir. I just have to change that. This was wrong, sir. After 12 hours of ECMO, patient pupil start reactive. Urine output was better. Heart function improved. EF is 25%. LV is distended. Now the patient is planned for PCI and might require LV venting. And after 6 hours only, ABG start improving. Lactate trend start decreasing. Currently, the lactate is 3. This was the second patient. Patient was 55-year-old male with non-type 2 diabetic mellitus with hypertension, presented with acute onset breathlessness, cough with frothy sputum and loss of consciousness at home. On arrival to the emergency department, patient was in the cardiac arrest at the ramp only. It was witness cardiac arrest. He was intubated and CPR was initiated as per ACLS protocol. Estimated downtime was 15 to 20 minutes, following which ROC was achieved. Due to persistent hemodynamically instability, it was planned for ECPR. The patient subsequently developed recurrent cardiac arrest, requiring another cycle of CPR with ROC achieved after 6 minutes. Following discussion with ECMO team, obtained family consent. VA ECMO support was initiated. Initial right femoral cannulation was unsuccessful, and left femoral artery and vein cannulated and went on the flow of 2.5 liter. Due to there was a complication on right femoral side, patient was shifted to hybrid OT, where cardiologists performed angio and vascular repair right femoral simultaneously. On angio, it was showed total occlusion of LAD and RCA, and cardiologists go ahead with the LAD angioplasty. During procedure, patient develops tense abdomen, distension with inability to maintain ECMO flows. At the end of procedure, when the drapes was removed, his abdomen was like this and hardly could achieve 300 to 400 ml of flow after giving the fluid. It was suggestive of retroperitoneal bleed due to vascular injury due to cannulation. This was the angio. Their RCA is cut off. LAD was cut off. This is the after doing angioplasty. LAD is completely open. So this is how generally ECPR team does This is how generally ECPR team does ECMO cannulations,
Please be fast, yes.
where perfusion is priming the pump,
Open the
2% is
drawing,
the
open
priming
the
the
drawing,
pump,
please. Yes, yes, yes.
2% are doing the cannulation simultaneously, percutaneously, 2% is
Give me a
taking
sheet,
care
give
of
me a sterile sheet.
airway anesthesia,
Give me a sterile sheet. Yes. Sure. All clear. Please be fast, please be.
so here they have punctured the femoral side.
No. Yes, I am ready. Archel, can you please give me a guide wire?
Guide wire.
I'll be ready with the DP.
Please open the door. Give me another guide wire.
It is primed.
Please be ready with the
Dilator
27
is
stretch of
going.
venous and 21 of arterial.
Both are open and
Give me a
clamp the
clamp,
circuit and divide.
please give me a clamp.
Give one more. Saline. Want to change oil?
Increase the arterial first. Yes, remove the venous. Remove the venous.
Very good.
Increase the stretch of venous. Okay, I am removing arterial. Yes.
What is the flow?
Yes. Please look for the
All
oximeter
the things are
connected.
achieved. For this presentation, I've used all these resources. All are from ELSO, Red Book. Thank you.
Okay. You didn't talk about post-operative cardiac arrest. What are the things about what you do in the ICU after cardiac surgery? Is there a difference in the because resuscitation, you can't do chest compressions and other things with the sternotomy wound. So how do you manage that? You could have
Post-cardiotomy.
included that.
It's a complete different topic, sir. I'll include in next class.
Okay. The other thing that you says you presented some statistics, but the last one was around 2017. You didn't have any recent statistics. 2017 is 9 years ago.
Tried to get the registry, but I was not able to achieve last year.
Sorry.
I tried to find all other datas, but I couldn't got that data, so I just presented the last one. What I got was till 2017. And
Is that the
17
last you have in ELSO registry is got only till 2017, is it?
no, they have till 2022, but there was no proper
So what-
graph.
No, ELSO registry has got proper statistics on everything related to ECMO.
Sir, I got till 2022. I couldn't got more than. So
You couldn't do what?
after 2022, I not able to access. But what
No,
I
but this is only till 2017. You still missed 5 years.
there was a huge jump in ECPR during COVID, where it was extensively used. So during H1N1 wave and COVID, ECPR jumped a lot.
So that is the reason to exclude the data, is it?
No, sir. I was not able to get that graph and all, so I presented 2017.
It's not there in the ELSO registry.
I tried to open, I was not able to get this that 2017.
You know, we subscribe to ELSO registry. So if you wanted the data, you should have asked Murli or Prakash to get our subscription. I mean, through subscription, we can get all the data.
Okay, sir. Next time. And the last two patients we did ECPR in Sunday. Out of two, one patient survived. He is still alive. He's awake. He's planned for an PCI and other procedure. And one couldn't achieve because of retroperitoneal bleed due to cannulation complication.
See, one of the things which determines all these guidelines and procedures that are made is the fact that many of these people who cannulate are not surgeons. So they do peripheral cannulation, they do percutaneous cannulation because they cannot cut. I am sure that any surgeon can put in a set of pipes into the chest a lot quicker than what you can achieve from a peripheral cannulation. In terms, you also said 3 to 3.6 liters of flow, and that is a spot which you're not going to get with peripheral cannulation usually. Most of the times you see 2.5 liters of flow, and 2.5 liters of flow is very inadequate for tissue perfusion. So let's not forget that the way these guidelines are made are mostly by non-surgical people, either intensivists or some of them are not even doctors. Ayurveds or people like that are the ones who sit on top. And the one which you showed in terms of ECPR, that is not a good one, because that is on a mannequin. Those people have not even tied their gowns. That is not the way to do ECPR. ECPR has to be done in a proper manner. That is a competition, so they cut corners everywhere. The team includes you, I think, but from the picture. So if I was the judge, I would have disqualified you. Now, see, there are some times which you have to mention that there when you look at ECPR, there is a time between the point of arrest to start of resuscitation or CPR. That is a time when there is no flow, and then there is a time when there is CPR, which is considered as low flow, and then there is a time when you have return of circulation at adequate flows. So all these have got a bearing on the outcomes in ECPR. And you must remember, most of these people who arrest are not just arresting from being very healthy with good circulation. Many of them would have had a problem, and then their circulation gradually drifts down, and maybe they're acidotic and in low cardiac output prior to arrest. So that all the organs are already on the brink. And then when you have an arrest, if you cannot put the circulation back to normal, they're really not going to get much better. And again, you should also consider that the time people are massaging, then they inform the team. Once you inform the ECPR team, they're not going to come here and put it in 2 minutes. A lot of times it takes a lot longer than that. So if you inform somebody after half an hour, and if they're going to take at least 10-15 minutes to come here, and then take at least 15-20 minutes or even 30 minutes or longer to cannulate, the match is lost. So one day, Dr. Bartlett was telling me, if somebody calls you after half an hour of CPR, don't even go. You might eventually decide to put it, but generally the outcomes are poor. So when there is an arrest, you should be involving the team right away so that people can come in and start working on a strategy of ECPR. And there are a lot of times when we have gone and done it centrally without. See, all you have to do is open the chest, put 2 cannulas without any purse strings, and you can achieve circulation in no time, and you can do all your other things later. And there may be more bleeding, but then here also you see that retroperitoneal hematoma, which is no different. And again, when you are going to do open cannulation, I would recommend not to put needle and guide wire and all those things. You just cut open the vessel and cannulate. You're surgeons, for God's sake. You're not intensivists. So you know how to repair a vessel, or there is somebody around who can repair a vessel. So you must always put it under vision through a vessel with an adequate sized incision, not through a keyhole. All this semi-Seldinger and all that is good for other people. So if you can safely do it, it's fine. But otherwise, you should just go ahead and do that. Again, when you look at fluoroscopy versus ultrasound, one is not a substitute for the other. Ultrasound is to locate the vessel. That's it. It has got no other role. Beyond that, it has got no other role. A guide wire cannot be located properly on ultrasound or echo. A guide wire can fold upon itself on the cannula, and the whole complex and guide wire, everything can perforate a vessel, and the echo will not show anything. Echo is great to diagnose tamponade, but not to prevent it. So if you have a fluoroscopy, you can see that the wire is bent on itself, and you can see the progress of the cannula because they are all radio opaque. So the safest way to cannulate is to use a fluoroscopy and ultrasound, not one. Ultrasound is only good for puncture. It is not good for cannulation. And it is a myth that echo will help you to position the cannula correctly. I see that Dr. Murli is here. He might object to it, but this is a known problem that echo will not help you in cannula position properly. Again, you showed on your pictures that the cannulas are placed on the left side. Is there a preference between left and right when you have choice?
I
And
prefer
why so?
to do it on right side
Why is
if I
that?
have a choice.
Why?
It will go straight direction compared to when it goes
No,
from the left.
no, that is not the reason. You have to give anatomical reason. Remember, you're not a third year MBBS student. You're supposed to know the anatomy of the vessels in the abdomen and in the chest.
It's on a right side. That's why your
What is on the right side?
aorta in your IEC.
Aorta is not on the right side. You're digging yourself into a larger hole.
When you cannulate, your path is more straighter on righter side compared to your lefter side.
That is not the reason.
Which vessel is more prone for injury?
You pull up a picture of the common femoral, sorry, the common iliac, external iliac, internal iliac, and abdominal aorta from that same thing. You had that there. Just pull that up on your slide, in the cannulation slide. No, lower. Ah, yeah, that's fine. This is not correct. You get another picture. The lower one where the cannulation is shown. Anyway, this is not depicted correctly. On the left side, the iliac artery will cross the femoral vein, and it becomes difficult to get across that portion. In the right, it is straight, and there is no crossing. Here it is shown wrong. That is the reason it is easier to cannulate on the right. And also, if you want to do a septostomy and pass the cannula into the septum, it is simpler to do it from the right, even though it is possible from the left. And you didn't mention anything about venting the LV and the strategies for that.
Also, the right iliac vein is almost in continuity with the IVC, so it is easier to pass the cannula through.
Yes.
And when you have a presentation, you should structure it a little better. I think overall structure of I know you showed it to me, but it is for you to structure a presentation a lot better. It has to have a flow, whatever presentation you make. This didn't have a proper flow. It was just jumping from one place to another. It is just my observation. I don't know if others agree with me or not.
Talking about the presentation, I think you should restrict saying your thing, you do this thing and things like that, One does not tell the examiner or the audience what you should do.
I agree.
So what is done is described, in your this thing, in your this thing. That is not a nice way to say.
It's not a nice way to say anyway. I mean, that seems to be a very common way of expressing here. I do not know how that came through. This is your Ilia cartridge. This is not your Ilia cartridge. This is the Ilia cartridge. Yeah, I had also noticed that. Anything, sir?
No, I thought too much of technical, but you didn't talk much about the actual principles of this sort of resuscitation. You should have, I thought, got the impression that it's only for VF and VT, but actually when there is circulatory arrest, there is a VF, there is a VT without pulses, there is cardiac arrest, systolic arrest, and then pulseless electrical activity of these are the conditions where they need resuscitation. And of course, that you have learned in basic life support and advanced life support. When you say about ECMO life support, should have mentioned what are the important things. When to start it, I think you mentioned that the most important thing, Julius is an expert on that. The most important thing is the venting of the heart. Because when you put them on ECMO, if the left ventricle, which is already working at low pressure, the strain is on the left ventricle and they all develop pulmonary edema because of the left side pressure goes up. So the most important thing is venting of the heart. One, percutaneous, pulmonary venting, percutaneous, transeptal venting. Then, Julius used to tell you, the impeller. Of course, one of the best things is the EC plus impeller, so that, the ventricle dilatation and the strain of the ventricle is not there. Should have mentioned those things. And of course, as Julia said, it would be much easier to open and do the venting, and it may get better results also. And also the other thing you didn't mention, about what is the anticoagulation manage, because that's the thing which every student should understand. One, what is the anticoagulation management, and what is temperature management, the targeted temperature, We used to say that, mild hypothermia on ECMO, 33 to 35, that's helpful. And actually, there are some papers where deep hypothermia and circulatory arrest in a patient who had a prolonged arrest, something like a induced coma, so that, the demand for oxygen in the brain becomes less, and they are supposed to have slightly better survival and probably better neurological outcome. Then you didn't say anything about the anticoagulation management. Suppose because of ECMO, and also sometimes the ventricle is not contracting enough, the aortic valve may not open, so the stasis of blood in the left ventricle may lead to clots, So the anticoagulation, normally we keep the ACT 180 to 220. Julius can correct me, this is all old information I've got. So those things you have stressed, and how long this goes on and that.
So
And
the
then-
ACT part is correct. That
Yeah.
is the correct ACT which we maintain.
Yeah. And
But
then
the thing to remember is that the LV is not contracting, the aortic valve is not opening, regardless of what ACT it is, the LV will clog.
and the combination of IABP, because the afterload is reduced, all those things, You should have mentioned something, actually. Julius is an expert in the venting because very often these things need actually a surgical venting or percutaneous venting, that you didn't mention at all.
Yes.
Then, then I
Uh,
said yesterday something about double sequential defibrillation. I don't exactly understand what it is actually. Is it practice?
I do not
What
know
I
what that is, sir.
Double sequencing defibrillation, if you permit me to say, the theory is that when we put the defibrillator pads, one under the right infraclavicular region and the other one in the apex, you are passing through one vector of the heart, and these people who have proposed the double sequence defibrillation, they say that sometimes we miss the vector of the heart, which is responsible for the ventricular fibrillation in a given patient. So they want to put one in the front and one in the back, and one right infraclavicular and left lower chest, that is the apex. And by saying that the success of, they give two defibrillatory shocks, one after the other, using the two vectors, and they say that this is going to be more successful than single vector defibrillation. That's what that is the background of that one. And a couple of points I would like to mention is that Barclays 24-hour legacy webinar is actually ongoing now. Since yesterday 5:30 p.m. It will end today at 5:30 p.m. That is one. Secondly, regarding the role of echocardiography and the ultrasound in ECMO is that before you make the decision to go on bypass, ECMO, sometimes echocardiography is used to assess the lung function or the heart function. And the second area is cannulation. Of course, Dr. Julius has said that location of vessels, you can use ultrasound. And then for monitoring of the during the ECMO run itself, and weaning, of course, weaning of ECMO, the echocardiogram is extensively used. And then after weaning also, continued vigilance or surveillance is done by the echocardiography. These are the stages at which echocardiography is useful. That's
I might
this.
disagree on the weaning part because there is one patient in the ward at the moment, and
Right,
there was
right.
another patient in the past where they said the LV is not contracting very well. In the absence of the vent, I just my answer to that was do not do any more echoes. We just wean. So echo is not a good parameter to assess the LV contractility when the LV is working against a very high amount of afterload from the flow. Once
Sure,
you
sure,
remove the
sure.
echo, in spite of the amount of flow that is going into the aorta, if the LV is still contracting and it is still ejecting, it is likely to eject when you remove the afterload.
Right, right. Probably you have to reduce the flows and check the VTA and things like that, so that you will get a realistic estimation when patient is on VA ECMO. Thank you.
other
Personally, I
than the
wouldn't give it a lot of
anatomy of the
importance.
other than the anatomy of the vessels, I think for a right-handed person, it's always better to stand on the right side of the patient and cannulate the right femoral artery and femoral vein. I mean, I don't know whether that's correct or not, but that's what we used to do. Okay.
And also, if you have two operators, if you can
Yeah,
simultaneously do both sides,
yeah.
even though the recommendations for ECPR is same side. I don't know why you could still do faster if you have two operators and doing on either side. But I tell you, chest is a lot faster. Whenever I've had to do in theater, we just cut through the chest and put large hoses. Not these tiny cannulas. We put very large cannulas so that you get good flows.
Yes.
And you said uh, the femoral incision can be transverse or vertical, but it's easier to do vertical to get the That's my impression rather than the translation.
Yeah. Personally, I also make vertical incisions, but here there are a lot of people who make incisions which are parallel to the crease for more cosmetic reasons down there.
Because the idea is to get the common femoral artery, the profunda, and the superficial femoral, So to trace all of these things, I thought a vertical incision is much better, easier.
And also, when the way I cannulate the vein in an open cannulation is through the saphenofemoral junction. If you are doing the saphenofemoral junction, you don't have to go around the vein, which becomes very difficult because there are a lot of tributaries which go at right angles right posteriorly. And if you injure one of them, it's very difficult to get control of that. So if you just do, everybody knows how to get the saphenous vein. Once you get the saphenous vein, you just destroy that saphenofemoral junction valve, and you can pass a very large cannula through that. The vein will distend to accommodate any big size cannulas. And then when you finish, just tie it off. You don't have to repair anything. That is my choice of cannulation. And for the artery, I just make at least 1/2 incision on the artery and then cannulate directly under machine.
Okay. Any other comments? Anyway, I think we can.
I thought, in the statistic, you said about out of hospital, the survival are in the hospital, there's only 28 and 34, some slight difference. But in India, most of them medics, they are not used to defibrillation in the resuscitation, massage and defibrillation. Western countries, it's okay. But in our country, the out of hospital arrest have got a higher mortality and neurological injuries.
Yeah, I know when we were being told in the induction classes while in Australia, they said, if you're at home and you know that somebody is having a VF, don't massage, you go and call the ambulance.
Yeah.
They will get here within 8 minutes. So if you waste time massaging, you're not going to get much output and you're wasting time before defibrillation because somebody who's fibrillating will need a defibrillation. You're very unlikely to revert them with massage.
What is our own statistics with ECPR?
I don't know the exact number but I don't think it would be great. Nothing to write home about. We have not been doing. See, it's one thing if you look at post-cardiotomy once, but the other lot, it's not so great.
No, I used to get the impression previously, not as Julia said, that if there is ventricular fibrillation, you massage few times because then the coronaries get some oxygenated blood, and that is what I used to think, so the defibrillation becomes easy or not. I'm not sure Julius will be able to say.
No, sir. This statement was because this is a home thing. Unless you get a defibrillator, and it's assured that they will get there within 8 minutes.
Yeah.
So in a situation like that, this is an appropriate thing to do.
Okay. Okay. Yeah.
But Julius, at home, how do you know that the patient is in VF?
Yeah, that is what I was saying. If that they said, if you know, for whatever reason, it's a patient who is prone to fibrillation or whatever, like you had a previous episode, if you know. If you don't know, then it's a different thing.
Okay. Thank you very much. Thanks, Julius and Murli for joining us. Thank you, sir.
Thank you, Murali.
Thank you,
Nice
sir.
to
And
see you
Thank
after a
you.
long time. Thanks, Prakash. Thank you, Julius.
thanks.
Thank
Oh,
you.
Prakash is also there. Yes.
No, Prakash
Okay.
didn't say anything. Prakash, you have any comment to make? I didn't see that you were there.
Yeah.
No, sir, I was there. No, only thing is, sir, you told about sternotomy being more easy. We had saved a lot of patients on viral myocarditis, where I remember you taking directly from cath lab to the OT. But the problem with the ECPR is many of the times, as you said, the cardiac surgeons are not available, and it is always done in out of OR setting only, no, sir. So I think the future will be also that it will be more of femoral cannulation, right, sir?
Yeah, it'll be non-cardiac surgeon based. I
Yes, sir.
agree. But
Definitely, there is
we,
a lot of
we
advantage. Sternotomy is much faster. Venting can be immediately inserted with LV vent, and our success rate has been very high when we have done, especially viral myocarditis. We have a series of 10 patients where 8 patients went home, sir. With and I think out of that, you have only done majority, and Dr. Kumaran also did 1 or 2 viral myocarditis, sir.
Yeah, see, I remember one patient, I said, I don't even want any lines.
Yes, sir.
We just put them on ECMO and then worry about lines. Patient was
But
already intubated.
going forward, it will be more of femoral cannulation. Sir, one more thing, any additions on this automatic ECPR, that Lucas system or something? If somebody can talk about
No,
that, will
there
it be
is
useful?
there is a major limitation for us with Lucas.
Yeah.
It's because it won't work for you and me. It is designed for people Dr. Collins size.
Okay, sir. Or for India, there should be a separate this thing. I
Yeah.
don't.
No, it generally doesn't work on small statured people.
Okay,
You
sir.
might end up with a flail chest.
But
Can
otherwise,
I
it's
add something?
Yeah.
having said that, I know this patient whom we got from Sweden.
Yes,
That
sir.
lady, she was on Lucas for a good length of time. She wasn't a small person, but even then she was on Lucas.
Julius, you have
Murli, you
an
wanted to make a
experience.
comment?
Yeah. I just wanted to also point out the role of echocardiography, if you don't mind, because I'm echo person. So they are recommending use of TE in cardiac arrest and cardiac resuscitation. Now they are saying that when you are doing the cardiac massage, most often the massage is done onto the LVOT, not onto the LV cavity actually. So they are recommending that use of transesophageal echocardiography during cardiopulmonary resuscitation using cardiac massage.
That
So
that is when it is done by non-cardiac surgeon. We've seen where the heart is.
I on that this thing, Murli, how practical is it to put in a TE probe when somebody is doing a massage in an emergency situation?
that's an
I think
absolute
I
challenge
think that would
because
be a little far-fetched, I would say.
no, it's a challenge, but now these things are coming up in a big way. If you see the emergency journals, they are looking at the compression and where exactly the compression is being done to be able to achieve the best possible outcome in a given patient.
I must narrate this experience which I had before. There was this patient who arrested in the ICU, and they were doing external cardiac massage and getting a decent output. The it was Shraddha who was massaging. You know how big Shraddha is, but still she was able to get excellent output while she was massaging. Then I take him to theater, open his chest and start open massage, and I'm getting no output. So I was quite surprised that I was unable to get any output. Then I realized that the heart was so big that I was only massaging a corner of the heart with one hand. So then I started massaging with one hand behind the heart and one hand in front of the heart, like you would do in a external massage. And then I started getting some output. But then that was not sustainable, so I just put 2 cannulas and went on ECMO.
The CALS guidelines recommend 2-hand massage for internal massage. one behind the heart and one in front of the heart. That is the recommendation by the CALS. Maybe that's why you got a good output with that.
Yeah, I mean, that was just out of desperation. The heart was extreme. It was a Epstein, and the heart was really, really huge. So that is why, and the LV was kind of small. See, I didn't know the anatomy of the patient at all. The first time I'm seeing the patient was after the arrest. So thanks to ECMO, you don't have to know the anatomy. You just have to put some pipes and go on ECMO. Only thing was I put 3 pipes and then I realized it was all one chamber.
Sir, one more point I want to ask is during cardiac arrest, the blood vessels go into a spasm. So many textbooks recommend to go for a smaller cannula. You were speaking about the cardiac output or the ECMO flow of 2.5 liters. So is it okay to initially put whatever cannula, smaller cannula possible to establish circulation and later on change it over to bigger cannula? What is your thoughts on that, sir?
You know, my thought, I think
it as fast as
my thought is adequate flows or no flow.
Okay. No in between your.
No. If you want to provide flows, you provide adequate flows. If you provide 1 liter flow, you might as well keep massaging. So as I said,
in NH, have you any experience of ECMO with impeller? I
No,
suppose
sir.
it's supposed to be very
No,
good.
sir.
Yeah.
We've
I've
not
seen.
done that because impeller costs as much as an ECMO machine.
Yeah, it is expensive.
Disposables. The disposables of impeller is as expensive as an ECMO machine. We have done a few impellers for, there was one person following mitra clip who had a low output situation and he had aortic regurgitation also. So ECMO was not going to help him. Because if you have AR and then put ECMO, it generally doesn't work. So for him, we cardiologist put an impeller, and he was 90 years old, but he survived that. He went home.
Okay.
Sir, one last point I want to ask is pre-primed ECMO. Is it okay? Many centers in Australia they are keeping a primed ECMO up to 3 months. That is what some papers are suggesting, sir. Any take on that, or should we prime it only?
You know the answer to that, Prakash. You have cultured stuff out of 1 week old ECMOs, no?
Yes, sir. So in large centers like us, where we have at least 10 ECMOs in a month, we are even if we prime it, we don't waste the circuit. But smaller centers.
I am not too this thing about the practicality of that, Prakash, because see, how long are you going to keep that?
Sir, yes, we have a protocol that we use it within 1 week.
Then what happens after that?
After that, we have to discard the circuit if it is not used.
Earlier, people used to say, keep a pump primed and things like that, but that happens in a place like NH where you have 25 cases being done, so that you can always use it, from one theater to another, you can wheel it and then do it. But if people are doing only, on odd cases, then the pump would have gone waste. So similarly, I think keeping a ECMO primed all the time, I'm not too sure whether it will be practical.
In a week's time, usually it gets utilized. I don't think a week goes by without an ECMO.
Yeah, here NH it is okay, sir.
But 3 months, I think it is too much.
Okay.
I mean, even 1 week, I think would be probably pushing it because we have cultured gram-negative organisms out of primed circuits within a few days, haven't we?
Yes, 1 week it.
So gram-negatives for us are our residents. So we can't really extrapolate what is done in the West to our situation. They all walk around with shoes in the theater. That doesn't mean we should do that.
Thank you.
Srikant sir is here. Can you share your Mayo experience? Good morning, sir.
Good morning, dear teachers, and good morning, colleagues. Nice to see you all. I was just randomly browsing WhatsApp and I saw a message, join class. So I said, okay, let me relive my memories of NH. Nice to see everybody. For those of
Yeah,
you who don't
good.
know me, I'm
Good to see you.
Srikanth. I was a resident like you all from 2017 to 2023. And currently I'm pursuing my fellowship in the US. I'm in Mayo Clinic. So anyway, nice talk, Deep. Is an interesting topic. And I was listening to your talk. It was good. So just a few points from my experience here at Mayo, because we do a lot of ECPRs as well, especially in the emergency department. And so we have an ECMO team, like an ECPR team. So when a patient comes to the emergency department and he's coding, the ECPR is activated. And the team involves, of course, a lot of people. It goes to the intensivist, the chief intensivist on duty that day, and one of us surgical fellows, and also the ECLS team, the people who they're basically perfusionists. They have the pump ready to go. And just like Prakash sir was saying, we have a pre-primed pump here as well, but they reuse it every 2 days. So we use it for 2 days. We pre-prime it for 2 days and use it for some other case or some other ECMO case in case we need to change it. And for visualization, it's always we have two ultrasound machines. So one of us, usually the surgical fellow, goes to the right leg for goes to the left leg for the arterial axis, and the anesthesiologist or the intensivist on call comes to the right side for the venous axis, and both of them are done under ultrasound guidance. And when the emergency department intubates the patient, they also put in the TE probe, so that there is also a cardiologist who's in the room who's doing the TE to help us with the cannulation. And we also have a mobile C-arm, which is right outside the room, and they come in to give us live images when we are passing the guide wire. So it's TE plus ultrasound guidance with C-arm. So here, of course, the resources are not a problem, so we can use everything. And so once we get access, we as surgical fellows, we are told to attempt twice with ultrasound guidance for arterial access. If we don't get a good arterial puncture, we are supposed to cut down and get arterial access. And once we get venous and arterial access, we cannulate wet-to-wet connections and go on ECMO. And we immediately put DPC, a distal perfusor cannula as well. We use a 7 French sheath and connect it to the arterial cannula as a distal perfusor. And the patient immediately goes to the cath lab for a coronary angiogram. And then if needed, we bring them to the OR for Impella for left-sided venting. Usually here it's always Impella 5.5 for venting. And once we know the diagnosis, again, the workup starts, and then the ECPR can be a bridge to like recovery, to transplant, or to any other cardiac procedure. And as you discussed about the Lucas device, we use the Lucas device here because that gets rid of most of the people in the room, because CPR needs a lot of people. And Lucas device is a good thing as well as a bad thing. As Dr. Regular sir said, it's a little tricky when we use it on thinner patients, because most of the Westerners are very big. So this device works very well for them. But it's very important to know how to use it. We've had some disasters here as well. Even if you position that pod of the Lucas a little lower or at the wrong spot, it can cause very serious internal organ injuries. We've had major liver lacerations. Once somebody positioned it on the xiphoid, and they had a xiphoid fracture, and it lacerated the liver, and we lost the patient because of the internal hemorrhage due to this Lucas device. So Lucas is very good device, but one, it's expensive. It's a $35,000 device, but you can use it. I mean, you can buy one and keep it. It is going to come for a long time, but you need to know how to use it efficiently to have good results. And so this is how ECPR goes on here at Mayo. And of course, I think for any successful ECPR program, first we should have a good understanding of CPR among the public. Like recently, we had a patient, a 33-year-old patient. The patient's wife woke up at 4 a.m. She was pregnant, and she heard her husband having some agonal breathing in the morning at 4 o'clock, and she started CPR and alerted the emergency medical services, and they came in like Dr. Julius has said in 5 minutes, and they shocked him, and they brought him to the hospital. He arrested again, went on ECMO. Then the whole workup was done. Then he got transplanted. He actually went home a couple of days ago after the transplant. So such results are very nice to see with ECPR, but it started with the wife who recognized the arrest and did the CPR. Because if not for her, this guy would not have made it to the hospital. So ECPR is a very complex thing, and a lot of things actually matter. And as Srikrishna has said, for us as cardiac surgeons, post-cardiotomy ECPR is very important. And especially in the pediatric setting, we get a lot of problems because the anatomy is so different. We have had many major problems with ECPR in the pediatric ICU, especially if you're on call in the PITU. You should know what anatomy it is, because we've had patients who had an arterial switch go on ECMO, and people have mistakenly cannulated the PA thinking that's the aorta, because you do a Lecomte and the PA is anterior and your aorta is posterior. People thought PA was the aorta and cannulated the aorta and went on ECMO with the PA and flooded the lungs, and we've lost a few babies like that. So knowing anatomy, especially in pediatrics, is very important. And post-cardiotomy ECPR, as you said, it's a big topic. We can probably cover it in a different lecture. But these are all important points for us to know. And for anticoagulation, like Jairaj sir said, we use heparin-coated circuits. So until we establish the diagnosis or know what's the next step in the process, we don't anticoagulate routinely. We just go with higher flows, and since it is heparin-coated, we even go up to 24 hours without any heparin or any bivalirudin for that matter. So once we know established diagnosis and we know which way the patient is headed, we will decide about the anticoagulation. So these are some of the small points which I thought I should share. And if there anything else that I can touch upon, I'm happy to share.
Good to see you, Srikanth.
Good
Thank
to
you,
see
sir.
you, Srikanth.
Yes, sir. Nice to
Nice.
see you as well. It reminds me of the good old days.
Yeah.
Nice to see you, Srikanth, and hear from you. Thank you.
Yes, sir. I hope
Yeah,
everybody is doing well.
Yeah, we also use heparin-coated circuit. Now
Oh,
that's
okay.
Yeah,
mentioned
we are
this.
using heparin coated circuit, and we are
Oh, okay.
nowadays we are not adding heparin
Oh, okay.
to the prime, but for the patient, I think there is a small dose, 1 mg per kg,
Okay.
give during the cannulation.
We
Okay.
have done some without heparin also, and also for now for Centrimag also we don't routinely heparinize them in the initial phase. But again, if you're doing peripheral cannula, you barely ever get good flows, and
Yes.
that is not adequate to go heparin free.
Yeah, what we do here is we usually go with smaller cannulas. Of course, Westerners are very big in size, so we won't achieve good flows with them. So we usually put like a 17 French. And then once we have achieved some stability, if they are going to the OR, then in the OR, when you do a cut down, we can exchange the cannula for a brief, like switch to a 19 or a slightly bigger cannula. But yeah, but especially if you're doing ECPR in the emergency department, you don't have much control over things. We also try to go with a smaller cannula and achieve as much flow as possible.
I don't understand. There are people who do 12 and without any distal perfusion cannula. I don't know what kind of flows you'll get with 12 cannula. But they seem to be happy with doing that. And with 12, of course, you don't need any distal perfusion cannula unless you loaded with noradrenaline in the first place. Then any cannula is big. Are you coming for the ISHLT this year?
No, sir. I was there last year. This time it's in Canada. So due to some visa issues, I'm not traveling outside the US.
Oh, you're stuck there.
Yes.
So my visa has expired. So I have
You're
if I
coming
have to
back, is
restamp
it?
the visa, I have to come to India again to restamp. So that's a problem.
You're coming back. You're coming back now to work here?
I'll finish in June, sir. Once I finish, I'll plan on
Because
coming back.
people have been asking me for reference.
Really? Yes, sir. I'm exploring my options back home. Yeah.
That's why Colin's children don't let him come to India now, because Trump may not let him into USA again.
But Trump has got bigger problems. Nobody's going to let him anywhere.
I don't know when he's going to need CPR.
It was nice seeing you, Srikanth.
Yeah, nice to see you all as well, sir.
What's happening on the home front? I shouldn't ask this in public. Okay.
I'll call you, sir. I'll call you sometime.